Hello all. I would like to thank Mr. Antonianakis and Mr. Brilakis for the invitation and the organizing committee. I want to welcome you all to our course, and I hope you'll find it rather interesting. So, got nothing to disclose. We are going to discuss about the type 3 AC joint dislocations and the role of vertical and horizontal stability to the management of such cases. So, as it was said before, the main stabilizers are three: the AC ligament, the CC ligament, and the CA ligament, which all of them construct a strong structure and help to stabilize the joint. We also have the deltoid trapezoid fascia, which is a common aponeurosis of the deltoid and the trapezoid muscle, and it limits posterior movement and axial rotation of the clavicle. So 9% of the shoulder injuries involve the AC joint. Nearly half of those shoulder injuries happen in contact sports. The prevalence is higher in men, and mostly the age group is 20 to 30 years of age. So the mechanism of injury is usually a direct blow to the shoulder or by falling on an outstretched arm, as in cycling. The CC ligament is torn, the upper limb weight is not supported, the shoulder moves inferiorly, and we have an increase of clavicle prominence and tenderness over the AC joint. So historically, the research focused on the restoration of the CC ligaments, but recently, the importance of ACC ligamentous complex for horizontal stabilization has been emphasized. So it seems to be a synergistic contribution of CC and AC ligaments to the joint's stability. Persistent AP instability affects negatively the clinical scores and is a prognostic factor for worse outcome. So it's of high clinical importance to reconstruct both AC and CC ligaments. Various techniques to address horizontal stability have been described. So what to do? We have the Rockwood classification still. It's widely used, it's a treatment guide, and it can be assessed radiologically. We need imaging, we have X-rays, the AP view, the Zanka view, the Alexander view, which gives us a visualization of the override of the clavicle to the acromion. We also have the CT scan. So what are the indications and treatments for each type? Usually types 1 and 2 are generally accepted to be treated conservatively. Types 4 to 6 are mostly treated surgically. The controversy is over the type 3, where there's a variety of lesions from non-symptomatic to symptomatic. It's really not still a consensus about optimal management. Recently, a new subclassification arose, the one from the ISACOS subclassification, which divided the type 3 in 3A, which are considered stable, and the 3B, which are considered unstable and have pain-reduced ROM and scapular dyskinesis. So those that have those radiological and clinical findings have to be treated individualized. Certain treatment algorithms have been described, taking into consideration also the chronicity of the injury, which is another issue to be taken into account, making it crucial to identify which patients are at risk of failure with conservative treatment and address to them surgically in an early state. It also depends on the biological capacity of the ligaments to heal without biological support. So which technique? Numerous techniques have been described, still no gold standard. Suspension techniques with sutures, with grafts, screw fixation, clavicular hook plate. So what to consider? You have to consider if you are going to address the patient open or arthroscopically assisted, if you are going to go around or through the coracoid, if you are going to do anatomic or non-anatomic repair, or single or double tunnel. As far as the open procedures are concerned, they are less technically demanding. You might miss some associated intra-articular injuries. You make larger incisions, which may take longer healing time and may cause more pain. In the arthroscopically assisted techniques. We use smaller incisions. We have direct visualization of the coracoid base. Less adhesions are generated. We get better cosmetic results. Might have less pain, but it's more technically demanding. So, an advantage of the arthroscopically assisted technique seems obvious in terms of treating concomitant glenohumeral pathology present in nearly 30% of the AC joint injuries. So, around or through the coracoid, biomechanical comparison showed that load-to-failure ratio compared with normal anatomy was significantly better when the anatomic allograft was placed around the coracoid than through it, in cadaveric specimens at least. So, also when the final result resembled the normal anatomy, the fixation was superior in stability and strength, so anatomy matters. So what is normal anatomy? The trapezoid ligament insertion ratio is 17% of total clavicular length from the distal end to the center of the trapezoid tuberosity. And the conoid ligament is 31% of total clavicular length from the distal end to the medial border of the conoid tuberosity. So the clavicular tunnel positions is of crucial importance, as it is one of the major causes of failure if placed too medially. Medialized clavicular tunnels increase the loading of the construct. So there is a theoretical advantage in single tunnel imposing lower postoperative risk of fracture, but it's not quite proven clinically yet. So early versus delayed surgery, time of intervention, seems to be lack of evidence to support an optimal time for surgical repair. Maybe the early repair is favorable, but still no strong evidence to support it. The Rockwood type 3 dislocations can be treated surgically with good results, especially in young, highly active patients. So there's still need for consensus. There was maybe, but because the AC joint dislocation still remains a complex topic, many conservative protocols and surgical techniques that make difficult the comparison of the outcomes. Developing a consensus seems mandatory, which finally came in 2020, when it was decided that the true anteroposterior or bilateral Zanca view and/or Alexander view X-rays are sufficient for diagnosis. The ISACOS subclassification was deemed valid. The acute cases were set up to 3 weeks post-traumatic, and arthroscopically assisted anatomic reconstruction using a suspensory device with biological reconstruction using tendon graft in chronic cases was suggested. So our technique. We use 2 loop tapes, 2 millimeters around the coracoid process and the clavicle, so we have 8 strands of tape in total. We tie them over the clavicle for the vertical stabilization of the AC joint. We aim at encircling the clavicle about 3 centimeters medial to the joint, as you can see here. We use niche nodes and tensioner for high load and reproducibility. We drill 1 tunnel to the clavicle through which we pass 2 separate tapes of horizontal stabilization, approximately 2 centimeters medially to the AC joint. The 2 limbs of the first loop tapes pass posterior to the clavicle and the other tapes anterior. The 2 loops are passed over the clavicle and through the AC joint, below and over the acromion in an X configuration, as you can see here. The tapes are tied then with a niche node against tension to 70 to 80 newtons for the horizontal stabilization, achieving an X-type frame internal bracing. So we go around the coracoid, we do 1 clavicular hole. The osteolysis might be a problem there, but as I'll say later, we haven't seen something like this yet. It's difficult, though, to aim through the clavicle to the coracoid. We use tapes for horizontal stabilization, also looped niche node for secure nodes and tensioner. We do no drills to the acromion, and the sutures allow small movement in all planes. So this is one case, pre-operatively and post-operatively. From 2019 to 2023, we treated 18 patients, 17 males, 1 female, 13 on their dominant arm. There was 9 acute and 9 chronic cases. They were all type 3B, 16 primary and 2 revisions surgery. All the scores were improved from pre-operatively. The ROM also improved. And we have conducted post-op CTs in 6 of those 18 patients in a mean follow-up 30.6 months, 1 to 4 years post-op. There was no to mild osteolysis at the area. 0 recurrence, 100% back to previous type of work, and 9 out of 18 patients were back to their previous level of athletic activity. Our indications in young, active patients with type 3 ACG joint dislocation, we prefer surgical treatment. We propose, to be honest, achieving high rate of good functional and radiological results with strong vertical and horizontal stability and low morbidity is our purpose. We try to operate between 3 to 6 weeks. We're biased towards over-treatment than under-treatment, explaining this to the patient, because trying to restore the anatomic position of the scapula than trying to compensate for the sick scapula is more certain to achieve better results, taking into consideration the activity level of the patient and the horizontal component of the instability. Excuse me. So this is one case, 2 years post-op, 21 years old. Excuse me. He's a manual laborer, motocross athlete with a previous clavicle fracture on the same side. He has full ROM, no pain. He has returned to all his pre-op activities. As you might notice, there is some osteolysis at the coracoid, but it's... So our key points. We try to respect and try to restore anatomy. We have to be careful with tunnel placement. You have to always address horizontal instability. Time is of the essence, and consensus is important. Thank you for your attention.